So today's medical update is going to be about vector change defibrillation. Across the U.S., a bunch of cardiologists in the American Heart Association published a journal in the New England Journal of Medicine in November of 2022. And what this showed was that we had a lot of refractory VFib that was happening throughout the United States. Now, they define refractory VFib as 3 or more defibrillations. So after the third defibrillation, if you have not broken that VFib or that pulseless V-tach, they were calling it refractory VFib. And so they published an article, and what this showed is that out of 405 patients they enrolled in their study, this cardiologist did, that if they used standard defibrillation alone, and we're going to go through our normal way of doing it, that they were only breaking that VFib after the third shock 33.6% of the time. By doing a vector change, and all vector means is if I'm going to the right and all of a sudden I change to the left, that's a vector change. By them doing a vector change in their defibrillation, they actually were breaking, after that third defibrillation, 35.6% of the time. This actually created a higher survival to hospital discharge. We're talking neurological intact. So if you stay with your standard defibrillation, only 13% of those people after 3 or more shocks were we breaking that refractory VFib and they were surviving to neurological outcome. By doing a vector change, you had a 21.7% change in neurological outcome survivability. So what Dr. Nix wanted to do on this medical update was us go into how we've normally been doing our biphasic defibrillation and how we've normally been putting our pads, and we're going to start out with a completely different way of doing that first defibrillation, and then we're going to talk about actually doing a vector change in a minute. So we've all been doing this in the field forever. We've been putting the first pad up here right underneath the right clavicle on the right anterior chest wall, and we've always been putting that left pad down on the left mid-anterior axillary line. And what this cardiologist did is that he put some volunteers into a CT machine and kept the pads in the normal pad placement and did load joules to see what are we doing when we're sending the electricity through. Now remember, on biphasic, when you're having those two pads together, what they are doing is they are going to talk to each other. And when those pads talk to each other, they're actually going to measure body density, how much water was in there, muscle, bone density, and it sends a shock from the bottom pad halfway through the heart, and then from that anterior or that right pad back through. So you're getting a double defibrillation, a longer shock. And what he noticed is if we put our pads in our normal placement, that the electricity was coming through, we were missing that whole posterior section of the heart and a good chunk of the left ventricle. So he theorized, and American Heart said, yes, we agree with you, that if we keep our pads in the anterior placement, that top one up underneath the clavicle on the right anterior wall, and we put the next one down in the mid-anterior axillary line, that when you defibrillate somebody, yes, the biphasic's coming this way, and then the other shock's coming this way, you're still missing that whole posterior section and left ventricle of the heart. So American Heart went back and said, if you're doing your pad placements this way, this pad should actually be your mid-axillary line, and this should be closer to your 5th, 6th intercostal space. That might encompass a little more of the left ventricle, but you're still missing that whole posterior and a little bit of the left ventricle. So what we're going to do here now is instead of doing that standard displacement, we're going to start off with a vector change. We're going to put our pads in the appropriate place that actually Zoll and Physio Control say. They actually want your pads anterior and posterior. Your first pad, and remember your pads are labeled, so when you're looking at it, it's going to tell you which one goes anterior, but you're going to put it, here's your sternum, here's your left nipple. You want in between the sternum and the left nipple of the patient. So your anterior pad goes there. Your posterior pad's going to be, here's your left scapula, here's your spine. You want it underneath the left scapula next to the spine. When you do that, your two pads are sandwiching the heart. When they sandwich the heart, they actually get better communication to each other. They actually read the adipose tissue, the water, the muscle, the bone density, and you get a better defibrillation. When you put your pads anterior and posterior, you actually encompass the whole posterior and almost all of the left ventricle. Most refractory V-fibs come from the posterior and the left ventricle. By us starting out, any crew on scene, the first crew on scene, whether it's a BLS or ALS units, you're going to put your pads anterior, posterior, and hopefully this will keep our patients out of a refractory V-fib. When you do this, that first crew on scene, it does not interfere with the Lucas for when the ambulance arrives. You've already got your pad anterior and posterior. You're doing a better defibrillation on your patient, and it's not going to interfere with you putting the Lucas device on. The second crew that gets on scene. So if I'm engine 17, I get on scene first. I'm going to place my pads anterior and posterior. All right? Then let's say a rescue gets on scene. What the rescue is going to do is they're going to go back to the standard pad placement, that right anterior chest wall, and they're going to come down and put it as best they can in that mid-axillary 5th, 6th intercostal space, or at least closest to it as they can, maybe that anterior line. And what you're going to do is if that second crew on sees that they have them anterior and posterior, they've done 3 shocks, they're now going to do a vector change. So instead of defibrillating anterior-posterior, you're now going to shock from your anterior pads, hoping that that patient who might be in refractory V-fib is actually now maybe a right ventricle. Because remember, when you encompass these pads in these placements, you get more of the right ventricle and that anterior portion of the heart. Most refractory V-fibs are going to be posterior and left ventricle. First crew on C's anterior, posterior, we encompass more of the heart, hopefully preventing them from going to that third shock. If they do decide to go to a third shock, it's not going to interrupt the Lucas. That second crew on scene is going to put their pads in the anterior placements, and hopefully, if that patient's still in refractory V-fib, we're encompassing more of the anterior and the right ventricle and converting them. It's as simple as that. If you have any further questions or you need additional training, reach out to the EMS Operations Division.